her liver. We repeat biopsy, and we found that this lady had triple positive disease now, with strong positive hormone receptors and also HER2 positive. About past medical history, this lady had a number of cardiovascular problems, including hypertension, and she tried previously ACE inhibitor treatment. She had also dyslipidemia, type 2 diabetes, tachycardia, and some arthritis. She is also known for allergy to atenolol treatment, and at that time she had treatment only with pain management and some antihypertensive treatment. So at that time we had few questions. Should we start with chemotherapy or endocrine treatment? Do we need to include anti-HER2 treatment, or if so, could it be dual blockage or monotherapy? And also, what kind of cardiac protection or cardiac follow-up should we start for this lady? Based on results of Cleopatra clinical trial, we know that dual blockage for HER2 treatment is a little bit better than monoblockade. So we started with pertuzumab, trastuzumab, and weekly paclitaxel for this lady. Also because of bone involvement, this lady had amidronate treatment. She received 10 cycles of paclitaxel. And she had continuous maintained dose of trastuzumab and pertuzumab, and amidronate every 3 months. So after 10 cycles of chemotherapy, we had another question: how many cycles of Taxol should we give? How long should we continue with HER2 treatment? Once again, what type of cardiac protection and monitoring should we use? And the same question about bisphosphonate treatment. So according to cardiac monitoring, we used echocardiogram every 3 months, and this patient had almost normal measurements of left ventricular ejection fraction during the first 6 months, but 9 months after treatment, she had decreased LVF to down to 44%. And from oncology perspective, she had stable disease, and we think that it was good response for this treatment. So at that point of time, we stopped our treatment, and we sent this patient to Cardio-Oncology clinic. She had assessment with a cardiologist, restarted ACE inhibitor treatment, and 1 month after, she had increased LVF function, and we restarted her anti-HER2 treatment with trastuzumab and pertuzumab. And for us it is very important, because from medical oncology she definitely requires additional treatment with pertuzumab and trastuzumab. And we know that continuous treatment with these 2 drugs will give this patient a better outcome. So we have a few trials now about cardiac protection and monitoring. We can talk about PRADA trial. They showed some benefits from candacertan treatment and no actual effect from metoprolol treatment, and another trial that has been presented last San Antonio that showed some small benefit during HER2 treatment with trastuzumab. According to this case, this patient had dual blockage, and we still do not have enough experience about cardiac toxicity during dual treatment with pertuzumab and trastuzumab. We have some experience that cardiac toxicity is almost the same, but still I don't think that we have enough clinical based data, not from clinical trials only. About benefits for this patient, we have long discussion with Dr. Dent about this benefits and what type of disease should we treat, and when we have to stop with oncology treatment and go to cardiology treatment. And we did this diagram for discussion, and I think that we still need more information about risk assessment and risk stratification, because if you will talk, does everybody require this cardiac protection, cardiac treatment during HER2 treatment? I don't think so. We have population-based trials, and a few large studies has been published a few months ago from Ontario-based database. They included more than 15,000 patients and approximately 5,000 patients on trastuzumab treatment together, and they showed that cardiac toxicity rates less than 10% overall. So, in this situation, we need more tools to stratify risk of cardiac events, and maybe have special approaches only for patients with high risk. May I ask our members a question about cardiac protection for patients who has allergies, for example, like this patient to metoprolol or other medication? What should we use, and how should we monitor these patients?
What was the allergy to metoprolol?
She had skin rash at that time, and she told about shortness of breath, but it was not documented only skin rash.
I think it would be worth a trial of an alternate beta blocker like carvedilol. If it's not clear that it was due to the metoprolol, or not sure if it's a class effect.
Our cardiologist started with ACE inhibitor for this lady at that time, so maybe it was based on this anti-core study, but I think we still require more trials about cardiac protection and prevention. This lady from oncology perspective doing very well now. And
who's in the procedures today? Sarah? Okay, so you're about to start another procedure?
Sorry?
Someone's overriding this background. They'll have to mute themselves.
So is there a fellow with me or no?
I'll see if I can mute.
What is the case about? What is the case that they're doing?
Maybe that's Sonia. I'm muting Sonia. Hello, Olexiy.
Yes, yes.
I'm
Hi.
sorry. Someone didn't mute themselves, and there's some background noise, so I'm sorry about that. Let me ask you, I may have taken them out by muting them myself. I have a patient that's somewhat similar who can't take beta blockers. She doesn't tolerate the side effects, and she can't take ACE, and she can't take ACEs, and she can't take ARBs because of the side effects. And but we decided to try her, even though because of this, actually she couldn't take ACEs. She didn't say she couldn't take ARBs. She couldn't take ACEs, and she had a lot of experience with metastatic cancer, has gone a long way out, has a recurrence, and she had a drop in her ejection fraction of about to about 31%, and needed to continue on chemotherapy, and has been sort of almost a professional at this because she's been through so many cycles. And so we decided to try her on Entresto. And so we put her on Entresto, and within about 6 weeks her ejection fraction came back up to what it had been before, which is about 39%. And so that's my first experience with Entresto as our first line drug in someone who has some cardiotoxicity with breast cancer on chemotherapy. Has anybody in the audience had any experience using Entresto?
Actually, we don't have such experience, but may I ask you, what was the age of this patient?
This lady's in her 40s.
So I think that this is a very interesting question, because young lady, and probably we would expect very good response from our treatment, or she really requires this treatment from medical oncology side. So I think that we have to use any possibility from cardiology side to give you possibility to have oncological treatment.
That's good. Joe Carver, have you had any experience using Subutril, one of the combination drugs in Entresto? How about you, Sebastian? Have you had any experience with Entresto?
Yes, I have some comments, because I have in my practice, in daily practice, some women with the same clinical situation. And first comment, I have observed that the patients treated with paclitaxel may experience tachycardia or other types of supraventricular arrhythmias. And I think that beta blockers may be the best choice for these patients. And I like beta blockers because these women are sometimes with normal blood pressure, with low BMI, and with tachycardia. And I like beta blockers in this situation because due beta blockers, I can continue the treatment. And I have observed that tachycardia may be the first symptoms of myocardial dysfunction development. And when I use beta blockers as the first choice, I haven't observed myocardial dysfunction in the future observation. This is the first comment. And second comment, we have our European guidelines suggesting that the best choice are beta blockers and ICE inhibitors for patients with decreased ejection fraction related to chemotherapy or pertuzumab or trastuzumab, and I'm trying to use the both of drugs. What do you think?
Arjun, would you like to comment? How about Olexiy? Would you like to comment?
I can give only a comment based on the Manticore trial, and when they used this both medication, they showed just 1 or 2% increase in so better outcome in LVF fraction, but it was very small study, in only 99 patients in 4 groups. So I think we need more experience for this. And as I told before, if it is possible for us to give patients more possibilities to have oncological treatment which is toxic, we have to use all available options. So if patients require this medication, we can use both maybe. But again, it's less than 10% who really need this medication. And I don't think that we can use this in prevention for healthy people.
And can you agree that the woman with low blood pressure and tachycardia and with new myocardial dysfunction may be the best candidate for beta blockers?
I would recommend consult of cardiologists, our cardiologists who have some knowledge with this, and I will send this patient to cardiologist. And from medical oncology perspective, I will not continue treatment with low blood pressure, and I'll describe the situation for this patient, and probably I will wait for comment from cardiology. That's why I think that it is very important to have a multidisciplinary team, and we have cardiac oncology rounds every 3 weeks here, and we discuss all these cases and we make our treatment decisions together. So from medical oncology perspective, cancer is chronic disease, and we can stop treatment and we can give a few months holidays, and it will not affect significantly our treatment outcomes. But from cardiovascular, you have to think differently.
I see. So when you do stop treatment, how long do you usually wait before you restart it? How long does it usually take for the ejection fraction to come back up?
Usually we just skip one cycle of trastuzumab treatment. So treatment is every 3 weeks. So usually patients have 6 weeks window between 2 cycles, and in most cases this is enough to recover.
And so missing a cycle isn't really critical, is that correct? In terms of the cancer?
In terms of HER2 treatment, yes. Trastuzumab-based treatment. And another question, how should we monitor cardiac function? Now we use echocardiogram or MAGA testing every 3 months, but I think it's too frequent for 70% of all patients. So now we started this trial to show a non-inferiority between 3 and 4 months echo, and maybe in some cases we will not do it even every 4 months, but just before we start Herceptin and after we finish Herceptin. What do you think about this?
I know that with pertuzumab plus Herceptin, the guidelines in the package insert indicate information from the FDA every 6 weeks for a while when you start them. Has anybody been adhering to every 6 weeks?
Yes, I have heard about these guidelines from Mayo Clinic.
So do you routinely do every 6 weeks?
In Poland, we continue the monitoring every 9 weeks.
Eric, can you hear me?
Yes, I can. Would you like to make
Well,
some comments?
Yeah, finally. So
Finally, you're back on board.
no, we've had like microphone problems from the first time that you said good morning.
I've seen that, and I think you're back on you're on your phone now.
Yeah, so we on the phone. So
Very good.
so let me answer some serial questions that have been like lined up. So our experience with Entresto, not in the situation that you've described, but in people with chemotherapy-induced really bad LV dysfunction that's symptomatic on classic heart failure therapy. I've never been able to get beyond a half a pill of the lowest, the 24 dose of Entresto because of blood pressure. It's really been very frustrating, and I've not been very successful in getting a great benefit from that drug. As far as the monitoring with trastuzumab, we've really tried not to get echoes other than at baseline and after the first 3 months, and if nothing changes, we've really convinced the oncologists here not to pursue anything related to the package insert and follow them clinically. We do get BNP levels every couple of cycles, and without a bump in BNP, we don't get echocardiograms.
Good. As Joe knows, I'm probably the leading proponent on cardiac CT because it's so easy for us to do this in our facility, because that's my forte, is advanced cardiac imaging. And so a lady this age with several risk factors for coronary heart disease, we would probably do a CT on her just to take a look at her coronary arteries as long as her renal function was normal. And we would add that information to the rest of the information, knowing if she has occult underlying coronary artery disease. How that's useful, I'm piecing together a presentation for the meeting coming up in September to show what our experience has been.
Yeah, so Eric, I think that for everybody that any woman that drops their ejection fraction or has LV dysfunction on HER2 negative, HER2 positive therapy in the absence of prior anthracyclines, that it's probably almost malpractice not to look for coronary disease. In the anthracycline group, it's probably not malpractice, but we do it also, and unfortunately, you have a better situation in getting both the quality and the insurance approval of coronary CTs than we have.
So Olexiy, what do you think about looking for occult coronary artery disease in this lady, and would you consider cardiac CT?
It is not standard practice in Ottawa, so it could be recommended by our cardiologist, but usually as medical oncologists we are not sending our patients to this. But we have Heart Institute, and they usually advise to do cardiac MRI in this situation, but once again it's not routine practice for us, and maybe we have less than 10 patients with this imaging during the last year.
I see with patients who may be developing cardiomyopathy, we have a new opportunity with MRI to add something called T1 Moly, which will show underlying diffuse fibrosis as opposed to late gadolinium enhancement, which shows areas of spotty focal fibrosis. We now are adding T1 Moly to our repertoire of MRIs so that we can look for diffuse fibrosis. That's going to be kind of interesting for us. Looking forward to seeing how that application might help understand ventricles a little bit better.
Another thing, we are going to start a survey, and we have already received ethical approval about different ways to monitoring and follow up LVF function during and after trastuzumab treatment. So we will send invitation to participate in this survey for physicians, and I would ask to participate everybody, and probably we will have interesting results and we will present them during September meeting.
Very good. Olexiy, you were saying that for ejection fraction, sometimes you do MUGA, sometimes you do echo. Tell me, given those choices and those observations, which has been more helpful? Are they equally as helpful? Does MUGA help you sometimes for some things, and echo help you sometimes for other things? Is there any preference depending upon the patient? How do you apply MUGA, or do you apply them equally, MUGA and echo?
In our center, I think that we have like 90% echo and 10% MUGAs now, and the number of new procedures with MUGA decreased significantly. Our cardiologist proposed us new methods with strains, and they do this echocardiogram in special way, and now we use more and more echocardiogram because it's much easier for patients and give us enough information. For MUGA testing, I think it's only preferences of some medical oncologists who refer to MUGA testing, and as I told you, we have less than 10% now these procedures for monitoring. I don't know how in other centers, but in our, most patients now have echocardiogram only.
Joe Carver, would you consider MUGA obsolete and outdated, or do you think it's a reasonable choice?
Obsolete. The only time that we ever get a MUGA is when people have bizarre implants that you can't get any kind of good window and get a reasonable look at the ventricle, even with contrast. So every once in a while we get a MUGA, but the reality is that we don't use it. Less information, exposure to more radiation, so we don't do it.
Joe, would you do an MRI in the patient with implants so that you can get some beautiful left ventricular pictures?
Yeah. Agree.
And would you prefer that to MUGA then?
Yeah, I mean the MUGA is like 1970.
I don't think I've seen a MUGA for maybe 10 years. It took a while to train the oncologist to not refer patients for MUGA, but we did it, and we don't see any anymore. How about you, Sebastian? Do you use MUGA, echo, MRI?
Every day I use echocardiography for standard monitoring, but sometimes when the difficult problematic situation we use MRI, because when we should decide continue or not continue chemotherapy or other types of anti-cancer treatment, we use MRI to confirm when we can continue chemotherapy, especially in patients when echocardiography show 48% for ejection fraction. We use MRI for confirmation this diagnosis. In patient, in women, during adjuvant chemotherapy, because during metastatic disease, we can continue chemotherapy on trastuzumab, pertuzumab to first symptom of acute heart failure. This is our Polish guidelines. And sometimes we can use computed tomography with assessment of coronary artery, but we use this method in situation when we expect myocardial infarction type 2. So, for example, in patient with metastatic colon cancer, during 5 fluorouracil, patient may experience chest pain, and of course we can't observe decrease in ECG, decreased ST segment in ECG, and troponin may be increased, and we can't use computed tomography to confirm or exclude coronary damage, coronary artery damage, and of course we can continue the special treatment, antiplatelet treatment or other typical treatment for myocardial infarction. This is our Polish daily practice in my hospital.
Sebastian, frequently when we're doing the CT, or not infrequently, let's say, we'll run across a subsegmental pulmonary embolus. Obviously, there can be some false positives on that, but we do run across those, and in cancer patients, that does not seem to be uncommon. How do you feel about that? How aggressive would you be in the treatment?
Yes, exactly. This is the next situation. A cancer patient may experience dyspnea related to anti-cancer treatment or other situations related to cancer diseases, and of course CT angiography is the best method for differential diagnosis between pulmonary embolism, coronary artery damage, and other type of dyspnea. And when we can confirm pulmonary embolism, we usually start with antithrombotic treatment, and after 2-3 weeks of optimal treatment, when the hemodynamic parameters are stable, we can continue the anti-cancer treatment.
Do you use Lovenox, or do you lose the non-conventional anticoagulants, or do you use Fragmin?
We have Philips CT angiography, 128 slate multi-detector, and I think that is the good method, good approach for the diagnosis.
Joe Carver, would you like to elaborate a little bit on serendipitous pickup of pulmonary emboli? When I know you don't do much CT, but we run into them all the time.
Yeah, so, yeah, I think that if you see it and you really believe it's there, that you have to treat it.
Yeah, and how aggressive are you at treating subsegmental pulmonary emboli? You got one little embolus and a lower lobe.
Yeah, I mean, we generally treat them.
Can you just put them on like a non-conventional anticoagulant as an outpatient, or would you Lovenox them for a day or two and then do that?
Yeah, I think on the incidental ones where, I mean, we're not talking about somebody who comes in with shortness of breath and it's a PE.
Right.
The incidental ones, we have been using the novel oral anticoagulants, and I would say it probably happens 2 or 3 times a year that we see that.
How about you, Joe? Are the Europeans into novel anticoagulants? Sebastian, I'm sorry. How about you, Sebastian? Are you using the novel anticoagulants much?
Could you repeat the question?
Yeah, the question is in patients with pulmonary emboli that you run into incidentally, are you using novel anticoagulants much, such as Eliquis or Pradaxa or Xarelto?
Excellent question. We have the new study, and we will compare the standard treatment with dalteparin or enoxaparin with the treatment with apixaban. And otherwise, in daily practice, of course, we use low molecular fragmin, dalteparin or enoxaparin, because Europe like enoxaparin. And of course, this is the standard treatment, but in patients with breast cancer, when the pulmonary embolus was related to hormonal therapy, of course, we can decide that we continue the treatment with heparin during 3 to 6 months, and then we can continue with novel drugs. But of course, this is off-label treatment. And other situation is in patient with atrial fibrillation, and the special patients with atrial fibrillation required antithrombotic prevention, and we can't decide to use novel drugs. Of course, in accordance with European guidelines, when we can't use old and new drugs, and of course we have no data in cancer patients. We are waiting for this new data. But I can confirm that in next 2 years we will have our new Polish data, because we will continue this new study, the comparative study with apixaban and dalteparin in patients with pulmonary embolism.
Thank you. How about you, Olexiy? Novel anticoagulants much in Canada?
Our cardiologists usually prescribe Xarelto, and we have a number of patients on Xarelto. About 2 other drugs like Pradaxa and Eliquis. We have very few patients with this medication. So most patients have Xarelto. I'm talking about our center only.
I understand. On your slide here, you have high cardiovascular risk. What patients are you putting at high cardiovascular risk? What's the
very interesting question. We still do not have any of a good prediction tool. We can use Framingham risk score. We can use most common risk factors, including previous cardiovascular history and obesity, diabetes, maybe some other factors, but usually age also. Now we're working on how to do this prediction tool and how to stratify patients based on their previous cardiovascular risk. maybe we will present this work during a September conference because it is still in process.
That would be interesting. Let's see, we've got a few more minutes. I have a patient who's I'd like to ask you about, who's in his 70s, who had a previous old inferior wall MI, which was about 10 years ago, and had a stent put in the right coronary, and has done well since that time. Has an ejection fraction of 47% with regional dysfunction, and he has a history of getting new cancer, and is going to be on, actually he's had cancer years ago and it was treated with adriamycin, and now has a recurrence and is going to go back on 2 cycles of adriamycin and then go on another protocol. And they were wondering what the risk was of the 2 cycles of adriamycin to him. And he denies any symptoms of congestive heart failure, but prior to treatment has a high BNP and a high NT-proBNP. He had his first cycle and did well, and then developed some pedal edema. It was presumed that he was already on a beta blocker and an ACE, but it had inadvertently been stopped at some point. He's up for chemotherapy again this Friday, and he was started on Olexiy to get rid of the pedal edema. He had no fluid in his lungs, and his heart rate was normal, and he was started on beta blocker, which was Coreg, low dose with food twice a day. Would you send him to chemotherapy, his last course of 2 courses of adriamycin with previous adriamycin experience of a long time ago, and not a very high cumulative dose? Would you send him to this next round, or would you decide not to give another adriamycin dose?
Eric, what's his cancer?
And let me see. Let me hang on. Let me see. In just a second, I've got his chart popped up here for a minute. Thank you. And basically, he's got a little creatinine elevation of 1.5, and his cancer is lymphoma, and he had adriamycin 300 milligrams per meter squared in 2007, and now he's got recurrent, now high-grade lymphoma, and they want to do 2 cycles of adriamycin 40 milligrams per meter square each, and his ejection fraction in 2012 was about 45%. Recently it was about 40% or so, and each time it's been segmental left ventricular dysfunction of the posterior basilar portion of the left ventricle, the part that had taken the hit with the infarct. And he, after his first cycle, developed some pedal edema of 3+, but it was unchanged otherwise, and his NT-proBNP prior to starting therapy is 7,433.
All right, so I would tell you what would happen at Penn. A, that guy wouldn't have gotten any more adriamycin, and B, he probably, knowing the way that the oncologists do things, here he probably would have gotten several cycles of plain Rituxan. Or we would use substitute a multi-drug regimen and substitute etoposide for doxorubicin. But we would never have given that guy another round of anthracycline.
Olexiy, Sebastian, any comments about this gentleman?
How old was this gentleman?
He is 69. He's a young fellow. And high-grade lymphoma? Yes, sir.
What about target agents like rituximab?
Well, he had R-CHOP in 2007 with a maximum dose of 300 milligrams per meter square of adriamycin, and the current planned program was these 2 courses of adriamycin, and then some other therapy, and it hasn't been laid out to me. This is at the Moffitt Cancer Center, and I don't know what the other therapy was planned. That information wasn't given to me.
Yeah, I would just comment and then ask a question. From a cardiology perspective, I would certainly have a conversation with the oncologist and get an idea for prognosis and how vital the adriamycin was to the potential for cure or long-term remission. And if they really thought it was a much better option than any other options, and I would consider the use of dexrazoxane with the adriamycin or liposomal anthracyclines. And I just pose the question to you guys: how often are you able to have either of those options as viable options with insurance and with oncology?
Any comments, Joe?
I missed it. I had to step out for 1 second. What was the comment?
The question was, how often are you able to use liposomal derivatives of adriamycin or dexrazoxane as a cardioprotection? How often do you guys use it or are able to get it approved by insurance or by oncology?
Yeah, so we use a lot of dexrazoxane, and for people, like if this guy was going to get retreated and he was going to get CHOP again, and and he had no baseline LV dysfunction, we would speak with the oncologist and use dexrazoxane along with the doxorubicin.
And then the liposomal, do you use the liposomal much?
So the GYN people use a lot of liposomal doxil, and when they get to high doses and or recurrent disease, we actually use dexrazoxane along with doxil. But the medical oncologists don't use much doxil.
So I think everyone pretty much would skip this second round of adriamycin.
Definitely.
Given the information we have, and come up with some alternative rather than protective therapy plus adriamycin, correct?
Yeah, I think what Olexiy said is right. The guys here would probably see if he responded to Rituxan.
Right. Good. All right, I think we've just about beat this horse to death today, but I really appreciate the presentation. It was superb and raised a lot of questions, and I appreciate your attendance. We're looking forward to seeing everyone in Vancouver, and I hope you can make it this year. And we appreciate all the comments that we had today. And if you could thank the Susan Denta as well, Olexiy, appreciate your being on board with us this morning.
Thank you for this opportunity to present our case. Thank you so much.
Thank you so much.
Thank you, guys.
For your comments,
Bye.
guys. Bye-bye.
Thank you. Congratulations.
Bye-bye.